Welcome back. We're going to turn now to the respiratory system and its physiology, especially the lungs and the exchanges of gas. And then we're going to see how mechanically air is brought into the lungs, how physiologically gases are exchanged, and finally we're going to look at what can go wrong with this system as we do with every other system, the pathophysiology of respiration. First, let's turn back and look at our whole respiratory system in total, starting with the larynx at the very top, the trachea, which is a conduit for carrying air into the lungs, both bronchi and their smaller divisions, and these, as we mentioned, comprise what's called pulmonary ventilation. This is just the movement of the gas. When we get down to the very fine bronchioles and finally the alveoli, we're talking about pulmonary respiration. And if we move on and look at the next slide, we see that there are actually 4 places that this respiration can occur. One, in the very beginning, starts in what we call the room air. Doctors talk about room air, even though we mean air anywhere. We usually have patients in a room. But I use that expression as opposed to outside air because it's the way you'll see literature written, what the patient's O2 or oxygen saturation, for example, is on room air. The room air is the place where we take in a gas that is composed of about 80% nitrogen, which is inert and has no function at all in respiration, about 20% oxygen, and then a small amount, a fraction of a percent of other gases. This is the ventilation area. This moves into the lung in what's called external respiration, because it's on the external side of our system, and then we move into the blood cells in something called internal respiration. There's another area we haven't talked about, and that's cellular respiration. Once the gas is exchanged from the blood cells across into the somatic cells or the body cells, there's a whole very complicated system of respiration going on there. There are small organs inside the cell called mitochondria, which are energy producers and regulators, and the chemical respiration is going on inside the cell, the burning of the nutrients, the excretion of waste that have to be moved out again. And that's a very complicated process. In cellular biology, you could study that for a very long time. The microstructure is very, very well understood. And we can find a great many places where things can go wrong, and I'll talk about those in just a moment. The movement of these gases, the inspiration is what we call taking in air through our lungs. Expiration is blowing it back out. Now we have to make sure we don't confuse that with another term for expiration, which is when people die. In pulmonary physiology, we're just talking about air moving out. The external pulmonary respiration involves the exchange of gases across the capillaries. And we studied that last time. Air would move down through the bronchioles, just by way of review, into the alveoli. Oxygen-bearing gas would cross over into the pulmonary veins, which are going to go back carrying red blood toward the heart, and there'll be an exchange from the pulmonary arteries, which are carrying the deoxygenated blood, and they're going to get rid of their gas, the CO2, into the alveoli for blowing back into the atmosphere. Now, the next thing we need to study is the actual movement of the gases and how it is mechanically accomplished. I'd like you to look at this slide and try to ignore the numbers in millimeters of mercury. What they're showing you here is basically atmospheric versus the internal pressure of gases. It's a little easier if you just try to think anatomically what's happening. Here is the chest cavity and the lungs at rest. They show the diaphragm, the big broad muscle that separates the chest from the abdomen here as a line. The patient is now quiet, has not taken the breath. It's at the end of expiration. There is a very small difference in pressure between the atmospheric pressure that's inside the lung. Remember, the lung is in complete continuity with the outside air as long as your mouth or nose is open. So the pressure in the lung is going to be the atmospheric pressure. There's a slight drop in pressure on this side between the visceral and parietal pleura because that space is a potential vacuum. Now, nature abhors a vacuum. It's something you hear a lot in medicine. It always wants to replace the vacuum with something. When a patient takes a deep breath, the diaphragm goes down. This curved muscle over here contracts and becomes flat. It's the only way that muscle can move actively is by contraction. It can't move in the other direction. So when it becomes flat, it has effectively increased the diameter of the thoracic cavity. This, because this whole outer wall is fixed by the ribs, it's going to decrease the pressure between the lung and the parietal pleura. And therefore, air is going to be passively sucked into the lung just by that small pressure gradient, because the lung is going to try to keep that space filled. It's not going to allow the vacuum to become open. On expiration, the opposite occurs. The patient relaxes, the diaphragm moves back up, and there's a slightly increased pressure, relatively speaking, in the chest cavity relative to the outside air, and air is passively expelled into the atmosphere. Now, how this is accomplished in its finer structure is a different story. It's not as simple as it looked on that diagram, and try to keep a picture in your mind of a bucket handle. If you notice, the ribs have a slight downward slope from the back. This lateral view shows it best. The ribs are attached at the spine. There's 12 ribs, and these ribs slope downward and around to the front where they join the sternum. All this is movable. There's cartilage. As you see, the bone stops and is attached to cartilage here, which is flexible. And there's a joint back here, which allows movement. This movement goes up and down just the way a bucket handle does. If you notice, the downward slope of this bucket handle can be raised to elevate it. What happens to the diameter of the chest? When you pull up and raise the bucket handle, the diameter of the chest from front to back and side to side will increase. When you do the opposite and allow these ribs to relax, then the bucket handle drops down. Now, there's a great deal of elasticity in the chest cavity, so there's a natural response to go back to the narrower diameter and expiration. There are other muscles besides the diaphragm at work. If you're sitting quietly breathing and not exerting yourself, usually breathe at a natural rate of about 14 to 18 breaths per minute. The diaphragm goes down a very short way, maybe 2 to 3 inches, and air moves in and out of the lungs very quietly. The other muscles of respiration are not called into action. However, in a stress situation, we can have a lot more help. They're called the accessory muscles of respiration, and these muscles really come into play in running, exertion, stress, when you need to increase the amount of air moving in and out to maintain oxygen levels for the heart, the brain, and the muscles. So these include a whole bunch of muscles. The first group are the external intercostal muscles. There are little muscles that go between the ribs. If they contract, remember they're being held up by the first rib and the clavicle, the collarbone, and that's relatively stationary. So when each of these little muscles contracts, it helps pull the ribs up even further. And that's where you get the bucket handle movement I showed you down here. Now, you get other muscles that come into play. The sternocleidomastoid muscle, the big one in your neck that you see, can pull up against the head and help raise this circle of the first rib, sternum, and collarbone to pull it up a fraction of an inch more. And then you have other muscles here known as the scalenes, and they attach to the first rib and the clavicle, and they pull up as well. All these muscles tend to make that chest movement even more exaggerated. And there are some abdominal muscles. These are called the external obliques, and they also help as accessory muscles of respiration. It would be nice at times if you could forcefully exhale as well, so you can get the air out faster. The Diaphragm is unable to help you do that. It can only contract going down. It has to relax going up. It can't push out any of the air. That's a passive motion. However, we have the six-pack here on the abdomen called the rectus abdominis. That can pull things down and collapse the bucket handle. And we have another set of intercostals inside called the internal intercostals. Intercostal just means between ribs. Costal means ribs. And they pull the chest down again so that forced expiration can occur. I mentioned to you last time other accessory areas of respiration, the flaring of the nostril, for example, to get more air in. So we have a very big window of opportunity to change respiratory rate and volume and increase the amount of gas we can move. Now, in the deeper layers, we get to the alveoli, which again are really where the rubber meets the road. This is where the exchange takes place. I've shown you one set of schematic diagrams, and this is a much, much enlarged version of what I showed you here. If we look at this view, this would be probably the level of a high power microscope. Here is the alveolus, a single alveolus or air sac. And this is the single cell lining the wall. Here's where its nucleus is, bulging in a little bit. And it's lining and living right up against some very, very thin membrane. Remember, these red cells are only 8 microns, very, very small. This shows a capillary with the red cell in it, and these are a little folded up because the room is getting narrow. And look at the wall of the capillary, the thinnest part of the capillary, not the part with the cell nucleus, and this tiny membrane and the thinnest part of the alveolus are in direct opposition to each other. If you blow that up, for example, from this one, what you see here is that you're going to get diffusion. This part is showing red cells that have lost their oxygen, so diffusion of oxygen is going to go out across this very thin membrane and into the red cell, and then CO2 is going to come back to be expelled out into the atmosphere. This is the alveolar capillary exchange. The movement is dictated by very basic physics and laws. Boyle's law is one that describes the movement of gases, and basically it's very simple. Gases move from an area of higher pressure to an area of low pressure. We talk about partial pressures. For example, the atmosphere has a pressure that's composed of the weight of oxygen and the weight of the nitrogen and the weight of the carbon dioxide pressing down upon us. And we talk about these partial pressures to add up to the total pressure. So we have a partial pressure of oxygen, which was what we're most concerned about. And what will happen in a diffusion situation here, if we go back to the slide, is that the partial pressure of oxygen in the alveolus is higher than that in the depleted side of the red blood cell, and it will push its way in. The built-up carbon dioxide waste is higher than it is in the atmosphere, and it will push its way out. And there's a very strong gradient directing that movement. Now, carbon dioxide also has another function and in the gas circulation system. This is a rather complicated slide, and I only want you to look at a certain portion of it. It shows that carbon dioxide, our waste product, here on the venous side, depicted in blue, some of it's actually dissolved right in the plasma itself. Very small amounts, 7%. The rest of it is attached to the hemoglobin molecule in the red cell, about 23%, and that pushes its way out for exchange. There's also something called bicarbonate. When you mix carbon dioxide and water, you get some ions, charged particles, and a big percentage of this is the bicarbonate ion. Bicarbonate is a charged particle that's very good and useful as a buffer. A buffer system in chemistry is a system where you can change the composition by adding large amounts of acid or base, and the system will absorb like a sponge, like a chemical sponge, these components and only allow very slight shifts in pH. Many people are familiar with buffered aspirin. It's an aspirin that would be acid and irritating, but it has chemicals that buffer it when it gets in the stomach so it is not so acidic. Same thing happens here. The carbon dioxide system and the bicarbonate system allow you to pour in and remove large numbers of acid or basic ions and keep that very delicate pH balance. So if you look at, this is the pulmonary respiration, but also the same thing happens in the tissue. There's oxygen and carbon dioxide dissolved in the fluids. They can go back into the blood as a fluid component or into the hemoglobin itself. So what can go wrong here? Where actually can suffocation take place? First of all, pulmonary suffocation occurs from closure of the mouth or the nose at the throat by a foreign body. It can be any kind of a foreign body. You can get a lump of meat down there. All you have to do is cover someone's nose and mouth and they will be dead in a very short period of time. Water safety instructors always tell us, ask the question actually, how much water does it take to drown in? And the answer is probably a teacup. If you can close the mouth and nose with enough water and keep it that way, that person's going to drown. This is relatively uncommon at that level because the nose and mouth, except in cases of drowning where you can't get out of the water, you can clear your nose and mouth relatively easily. Even unconscious, a person can cough, can sneeze, or helpers can get to the nose and mouth to clear that airway. Further down, however, obstruction is rather more serious because you can't easily get access to the top of the airway, and even with instruments, it's sometimes difficult. So if you have any obstruction down in, remember we call this the hypopharynx, just above the airway, in the back of the mouth, any obstruction down here becomes a much more difficult problem. Now, the other places you can suffer a suffocation event would be in the alveoli themselves. If you get enough water, either fresh or seawater, down into the lungs of and into the alveoli, then the exchange of oxygen will be blocked by the water. There's some dissolved oxygen in water, but it can't get across the membrane. So, because of the pressure gradients. So that patient's drowning is just suffocation at the alveolar level. And finally, you can get tissue suffocation. You can get obstruction of flow from the capillary bed. For example, we mentioned a blood clot or an embolus. Well, what's going to kill that patient? It's actually tissue suffocation. If it's in the brain, the heart, some vital organ, you have stopped the flow of blood, but more importantly, you've stopped the flow of oxygen. That's tissue suffocation. And then finally, you have something called cellular suffocation. In cellular suffocation, something chemical is going on inside the cell itself. The easiest example of this is the metabolic poison group, such as cyanide. This is why it's so favored by spies and people who want to kill themselves, and unfortunately by a prison justice system that still in some states kills people with cyanide. Cyanide is a poison that acts inside the cell. Cyanide gets in there and completely blocks all cellular respiration. Nothing can happen. It's very quickly acting. It is absorbed across mucous membranes very quickly, just the way, for example, a patient who takes nitroglycerin just puts it under their tongue if they have a heart problem, and it is absorbed across the mucous membranes. You don't have to swallow it or chew it. Just put it against your cheek or tongue, and it is in a matter of seconds. It circulates to all the tissues of the body, which takes somewhere around 7 seconds, and you are dead. It is such a strong and potent metabolic poison because every cell in your body suffocates at once, or nearly at once. And the brain gets an immediate signal that something is wrong, that it is suffocating too. This is why cyanide gas works the way it does. The victim of the cyanide poisoning takes a very small whiff of cyanide. It smells like burnt almonds, actually. And the brain and every other cell in the body immediately knows it's suffocating. So what does the brain do? The brain orders a huge breath. And the person cannot fail to go, and take an enormous breath and get more of the cyanide gas in. So in a diabolical way, it's the perfect chemical poison. It forces you to take more until you're dead, which is usually 2 to 3 breaths. That's all it takes. There's virtually no antidote that can be given that's quick enough. You would have to take any antidote before you took the poison. That's how quick and serious this is. The common clinical obstructions I've just mentioned in the upper airway. Last time I mentioned epiglottitis, where the epiglottis got swollen because of viral illnesses. And then, so these are all upper airway in the pulmonary ventilation system. We have a gag reflex and a cough reflex. The gag reflex is in the back of our throat, and it doesn't allow anything to go down that hasn't been brought there by a normal swallowing mechanism. When you swallow, all that movement coordinates with the brain to tell the brain not to gag, to let the particles go down. But if you take a deep breath or you're talking and particles are not associated with swallowing, you start to cough and gag. We have a cough reflex. Anything that gets, if we look at this slide, down beyond the larynx in this tree, any foreign body besides a gas. And if there are droplet particles of fluid, dust, pollen, almost anything else that gets down there will cause violent coughing until it gets rid of it. Now, when you do a tracheostomy, one of the first things you learn to do is not to open that trachea to put in the tube, because you'll get a face full of coughed up blood and mucus. What you do first is you inject, with the trachea closed, a little bit of xylocaine. Patient coughs at the xylocaine, but then he coughs up into the face of the anesthesiologist, so you don't really care. And the xylocaine is sprayed up and down the trachea, and a minute later, that gag reflex is gone. The cough reflex is gone, and you can then operate without being bothered by the coughing and gagging. The another overall response that you get is called laryngospasm. Up here in the vocal folds, if anything touches that, not only do you cough and sputter and try to get rid of it, but your cords may actually just go into spasm. This is an overreaction of the body, which is a bad overreaction, because something touching the cords, which closes them, means that airway is shut and nothing's going to go through it unless you happen to have an instrument to go in from the top here or to make a tracheostomy from the bottom. The other thing to mention right here is that there are drugs that depress these reflexes. The gag and cough reflexes are seriously depressed by alcohol and by anesthetics. Now, I won't get into anesthesia too much, except to say that there is a stage of anesthesia on the way down and on the way out, that the vomiting center of the brain is highly stimulated. This is why you can't eat or drink anything before surgery, elective surgery. Because just before the vomiting reflex is stimulated, the gag reflex drops out. So on the way down in anesthesia, that gag reflex is gone, and then you start vomiting, and you can aspirate, which means to take solids or liquids into the lung, causing very serious and possibly deadly complication. On the way back out, again, after you start to wake up, the same thing happens. You start the vomiting reflex before you've regained the gag reflex. This is very dangerous and something that's the plague of every anesthesiologist and surgeon in emergency surgery, where we don't know or cannot guarantee the status of an empty stomach. We don't mind somebody vomiting if there's nothing in there to vomit. One of the maneuvers you're probably most familiar with is the Heimlich maneuver. Now almost everybody knows about that. The way that works is that when we have something obstructing the airway, we take the patient and squeeze just under these, what's called the xiphoid, or right between the ribs here. We get behind the patient, grab our fists, put our fists under the chest, not in the chest, and give a very sharp, violent contraction. What we're doing there is we're forcing the diaphragm up sharply because we're compressing the abdominal compartment. We're hoping there's enough air in the lung to act as a piston and pump the air up and pop out the particle or whatever's obstructing the patient from above. If you see this huge volume and you concentrate it down into this narrow cylinder, you therefore have something like a hypodermic syringe or a piston. And you're compressing a lot of volume into a small area, so you have high pressure. And in many cases, the plug, the piece of meat, whatever's there, will come flying out the patient's mouth. You don't do this by compressing around the patient's chest, because if you do that, you stand just as good a chance of making if you were, for example, to compress here, you might just drive the diaphragm down and not do any good at all. You need to apply all your force below the diaphragm so it goes up. I want to come back and look at something I mentioned in the last lecture just very quickly, and that is the tracheobronchial tree and its lining. This is the lung, and here's a representative section of what I told you about last time. It is lined with these basal cells and then what are called columnar cells, which are ciliated. They have hair. And these ones in the middle are goblet cells. They secrete mucus. These hairs beat, as in fields of wheat, in a certain direction, which is always upward and out of the lung. This is the way, as I mentioned, we get rid of pollen and so forth. This illustrates what happens when you smoke or are exposed to pollutants. You start losing the ciliation, and eventually you lose them all. You then get an increase in these cells, which ends up as invasive cancer over many, many years. And this is actually one of the worst cancers you can have. I always want to stop for a moment and bring up this issue of lung cancer because it pervades our society, and this is the proper place for it. I'll just tell you a story. As a surgeon, if 100 patients come into my office diagnosed with lung cancer, have an x-ray, a biopsy, whatever, 50 of those patients are unresectable and inoperable. Means I know before surgery, by x-rays, CAT scans, biopsy, that cancer has spread beyond any hope of surgical cure. They are then relegated to chemotherapy and radiation, which are poor treatments in this case. And all of those 50 people will be dead within 6 months to a year. That leaves me 50 patients. Of those 50 patients who I think are operable, when I get into the operating room, I find them 25 of them, or 25% of the total, are inoperable. Sorry, unresectable. Inoperable means you can't operate. I've already operated, but I can't take it out. I find something new that I didn't know beforehand and says, okay, it's open and close. That's now 75 patients dead within 6 months to a year, probably. It leaves me with 25 patients. I've now operated on them successfully, I think, removed the cancer. They recover, and at the end of 5 years, 8 of them will be alive. The other 2/3, even though I thought I could cure them, could not be cured. So of the 100 patients I looked at, I'm only going to cure 8, if I'm lucky. Now, when you translate that to 200,000 new cases a year, we're talking about an enormous loss of life and financial impact on the country for a disease that's almost wholly preventable by stopping smoking. Think of the amount of resources we pour into treatment, research, and so on every year for a disease that we can prevent. 98% of these patients would not have gotten their cancers if they didn't smoke. So that's my lesson for today. Let's move on now and talk about the central control of respiration. The brain, of course, is at the center of all of this. And it's an interesting area to study because this is one of the involuntary areas where the conscious meets the unconscious. We don't have very much control over our heart. We have no control over the involuntary movements of our intestine and other organs in the body, many of our endocrine glands and so on. But we do with our breathing. We can sit here totally oblivious to our breath, and it will go on. We can fall asleep, our breath will continue. We can be in coma many times, and the breathing will continue in many cases. However, I can sit here and hold my breath. I can breathe faster, slower, deeper, more shallow, and I can do almost anything I want and overcome within limits the natural rhythm of my breathing. Now, you can't do it to extremes. For example, you cannot hold your breath to death. what would happen if you could hold your breath to unconsciousness, which is very difficult, you would immediately begin breathing again. And the body, oddly enough, has set up a system where it is not the lack of oxygen that makes you want to breathe again. It's the buildup of the carbon dioxide. The need for oxygen is strong, and you feel like you need oxygen. I can't breathe, I'm suffocating. What's really happening is the carbon dioxide in your blood is building up because you're not getting rid of it. And that drives the brain's respiratory center far, far more effectively than the depriving it of oxygen. So what would be a good way to hold your breath for the longest period of time? Well, deep free divers know just how to do this. It's not important to take a breath full of 100% oxygen. What they do is they hyperventilate. They sit there and breathe as fast and as deep as they can for a minute or two, and what they're doing is blowing off the CO2, the carbon dioxide, dropping the levels of carbon dioxide. Then they take a big gulp of air or of pure oxygen and dive down and hold their breath for very long periods of time. So it's that drive that makes you take the breath, the carbon dioxide, more than the oxygen. There are centers in the brain which regulate this. There is a medullary rhythmicity center which establishes a normal rhythm in the brain. If you look at this slide, for example, this is the medulla. Don't pay too much attention to the anatomy. We're going to go right to this in the next lecture. But basically, there's an inspiratory center and a separate expiratory center. And this tells you when to breathe in and to breathe out. There is an apneustic area, which causes breath holding. And there's pneumotaxic areas, which also regulates the coordination of the respiration in the brain. These centers are driven and inhibited by very fine changes in blood chemistry, and it has to do with acidosis and alkalosis. When you're acidotic, have too much acid, you will breathe faster automatically to try to blow off the carbon dioxide, which gets rid of some of the acid component of your blood. The predominant centers that work here can be narcotized. In other words, they can be depressed by narcotics, by anesthetics, by alcohol. And the way a patient dies who's had a very big overdose of alcohol or narcotics is their respiratory center is depressed and they stop breathing. Alcohol is a total depressant as a chemical. It has no excitatory component at all. So everybody wonders, well, how come I get gay and happy and crazy when I drink? And that's because the first thing it inhibits is your inhibitions. It knocks out inhibitions and gets you overexcited, but then continued dosages start depressing every other center in the brain. And one of the tragic things in binge drinking, which is such a problem in colleges now, is that the students take a lot of alcohol and they get depressed. Then they take a lot more and their friends say, let's let him sleep it off. What's happened is that patient has lots more alcohol in the stomach that hasn't been absorbed yet. They go to sleep, everybody thinks they're fine, and then they absorb more alcohol, and that patient then has an overdose of alcohol that nobody knows about, and their respiration stops and they die. Or, during that anesthesia from alcohol, they get a vomiting reflex without a gag reflex. They vomit in their sleep because they've often been binge eating along with binge drinking. They vomit in their sleep, aspirate into their lungs, and they die there too. So it's like an anesthetic drug. In the old days, in the Wild West, it used to be used as an anesthetic drug, but it has too narrow a range of safety to be really used well. The range in which somebody is asleep so that you can operate is too close to the lethal dose. So we never use alcohol as an anesthetic agent anymore. Well, what are some of the things that can go wrong with this system? This system is a beautifully maintained and moderated system, but lots of things can go wrong when you have something so finely controlled. One of the things I wanted to talk to you about is called pneumothorax. And I think it's best to look at our original slide, in which we remember that we have the parietal pleura, we have the visceral pleura, and we have that potential space. A pneumothorax means literally air in the chest. How does that air get in the chest and what happens? If we make a hole in the outer wall Again, the Friday Night Knife and Gun Club, a bullet, a knife, stabbing, trauma of any type, makes a hole in the outer wall. Air will leak into the chest cavity and collapse that vacuum. Because there is a vacuum, it will suck the air in. What will happen to the lung? There's no longer a vacuum to hold the lung out against the chest wall. This lung will collapse. It can collapse partially or it can collapse all the way out. And at that point, it's not ventilating anymore. How would you treat that? Well, the easiest way for a surgeon to do would be to come in, air rises, so it's going to be at the top of the chest, the pneumothorax. Surgeon will come in and with a knife make a hole just over the top of a rib, between the rib spaces, and plunge a tube inside there and put it to suction and suck the air out of the chest until the vacuum is reestablished, and keep it out there using devices that we have that can maintain proper suction until the hole is sealed shut. That patient's going to be treated pretty well and pretty fast, not going to be much of a problem. The second thing that can happen is you can have a hole on the inside pleura. Suppose that visceral pleura tears. There's lots of ways that can happen. If you look here, it's very thin. It's in continuity with the lung. Well, that same knife, bullet, or sharp instrument that came through the parietal pleura could also go on and cut the visceral pleura. And in fact, that's what happens most often because they're right together. It'd be very hard to cut one and not the other. So now you have two leaks going on. You have air coming in from the outside, but you also have air coming in from the inside and leaking out and creating loss of vacuum as well. In that patient, if the tear is very, very small, you could still insert your chest tube. And by the way, you can also insert a lower chest tube to catch the blood and get rid of that you're surely going to have. And suck very, very hard with high pressure vacuum and suck it out until the inner portion of lung is pressed up against the chest wall and seals the leak. These kind of injuries cause inflammation, so it very quickly becomes sticky. All those things we told you about in the blood, but any irritation, inflammation will stick it out there, and you leave that chest tube in anywhere from 5 to 7 days. And then at the end of that time, you clamp the chest tube. If the lung doesn't recollapse, then you put your finger over the hole, pull it out, put a stitch in, the patient's fine. But then it can always be worse than that. We can have a really, really big tear. If we have a really, really big tear, there's no amount of suction is going to stop the air leak. And so what we have to do at that point is open the chest and sew, or today staple, the hole shut, and then put in our chest tube. Every time we open the chest for lung surgery, or even for heart surgery, if the pleural cavity is open, we have to put in chest tubes to reinflate the lung. Now that's one way this happens. Another way, which is kind of interesting, is for some reason tall, thin, young men get spontaneous pneumothorax. Man will be walking down the street and he'll go, oh, feel a terrible pain, which is the tear, and all of a sudden become very short of breath. And if he's healthy, he won't become terminally ill very fast, but he'll show up at a hospital, get a chest x-ray, and they'll see the cap of his lung looking like a little balloon with no vascular markings, just air inside the chest. And they'll immediately put in a chest tube. That patient will be fine, probably never have it happen again. There's another way this happens, somewhat more common, in a disease called emphysema. I mentioned to you last time that smokers or people who take polluted air in on a regular basis, like miners without masks, get a disease called emphysema. In emphysema, the elastic tissue of the lung starts to break down. And those little individual alveoli that are next to each other, the intervening walls break down, and 2 become 1, and 4 become 2, until you have a big empty sac, like an overinflated balloon, that's not exchanging any air at all. And the whole lung eventually becomes filled with these empty sacs, and you only have a portion of the lung left that's doing any exchange for the patient. These people are very unhappy. They are laboring at their breathing all the time. A lot of the time they don't give up smoking, though God knows why, but they continue to do the behavior that got the emphysema, and they eventually end up dragging around a little oxygen tank and needing full-time oxygen just to breathe. There's no cure. There's no treatment. Now, when these blebs, this this little bubble of alveoli are called blebs. When this bleb is near the surface, it can rub and tear and cause a pneumothorax. Then that patient is very, very much in trouble. That patient already has compromised respiratory function, can't get enough air in or out, and that patient's going to have a lot of trouble and may die unless you get a chest tube in there immediately. Still another way to get pneumothorax, which is why I've brought it into this lecture because there are so many ways, is in little babies. Little babies have very fragile tissues. They're strong in many ways, but their tissues are really fragile. Sometimes during surgery, the baby has an airway put down here with a balloon blown up to get a nice tight seal, and the anesthesiologist is bagging them, moving the air in and out by hand or by machine with set pressures. Same thing, by the way, can happen to an adult, but it's more common in babies. And it's just that the air pressure is a little too much for that little baby and pops a bleb. And it's happening under anesthesia. Patient doesn't show you any signs of pneumothorax. They're not short of breath because you're breathing for them, especially in an adult. You're doing all the breathing. You don't get that initial sign of pain in the chest, shortness of breath, because they're not awake to let you know that's happening. What happens to that patient gets something called a tension pneumothorax. The air is being now not brought into the lungs passively, so that when you have this vacuum intact normally and you then allow air to go in because of the way the atmosphere is doing it, for example, here, this is all passive. The pressures are very low. If this patient has somebody with a machine or an anesthesiologist pumping it in, air is coming in and out that tear under high pressure. And it not only collapses the lung, it eventually fills up the chest with air and actually starts pushing the chest over to one side, let's say from the right to the left. Now, those two cavities are not continuous, so nothing's happening to the left side of the chest here except it's being compressed. Its ability to breathe may be compromised, but before that happens, something's going to happen in the middle. Remember the heart hanging on the aorta? And also hanging on the two veins is sitting there like my fist, hanging on vessels. It's sitting about like that, and the chest is now being pushed over. The whole mediastinum is being pushed over, and the heart starts to rotate. This compromises the output, puts nerves on stretch, and starts to put the patient into heart failure. What happens in the operating room, everybody's sitting there, dumb, fat, and happy, and then we start to see the heart rate speed up for no reason. We start getting signs of cardiac distress. And a good attentive anesthesiologist, of course, should have a stethoscope on that chest very often during the operation. When he sees that go wrong, the anesthesiologist will then quickly listen to the chest and hear no breath sounds on this side. They'll know immediately what's going wrong, ask the surgeon to put in a chest tube, and air will come rushing out, and the problem will be solved. The key there is picking this up very, very early and getting the problem solved. Let me move on to one other area now that has to do with both the heart and the pulmonary system. It's called pulmonary edema. Edema means fluid in tissues. It's not where it's not supposed to be. In pulmonary edema, that's called cardiogenic pulmonary edema, the heart begins to fail. The heart can fail on either the right side or the left side. It can fail on both sides. Now, if you remember, when you have a heart that fails on the left, we're receiving blood back from the lungs, right? That's the part that's going to pump it out to the body. It's going to come back from the lungs. If the heart is not pumping out blood as fast as it's receiving it, blood's going to back up into the lungs. It's going to back up in those vessels and under such pressure that it's going to push through the walls. It's going to seep like a leaking sponge and fill the alveoli with fluid and the spaces between the alveoli with fluid. The person is going to literally drown in their own secretions. And that happens in heart failure from heart attacks, from chronic heart illnesses where the digitalis may not be regulated well. And that patient will present with first shortness of breath and then frothing. Because it's like a sponge, they will cough up a frothy sputum. And if blood breaks down, they'll cough up bloody pink sputum. So you might ask, what happens if the other side fails? Well, the right side is connected to the body, goes back through the vena cava, up to the head, back to the body, and you'll get edema. The patient will have swelling of the legs. You've probably seen this in elderly patients. They will have swelling of their abdomen because fluid will pool there. Liver will get big and tender. And then this can happen on both sides at once, so they'll both get edema in their body, called peripheral edema, as well as pulmonary edema. Pulmonary edema is an emergency. We immediately give drugs. If there's fluid in the pleural space, we'll tap that out with a needle. It certainly is something that has to be handled very, very quickly and effectively, or it will lead rapidly to death. That ends our trip through the cardiovascular and respiratory systems. Next time we'll pick up with the brain.